drama with in my pocket. My brother forget to drugs go shut in your life. Fight it, no they sit down, they do nothing. I cannot open eye, make it drugs to wound me. Even though something must to kill a man. I cannot open eye, make drugs kill me. I go stand up and go look for professional help.
Drugs get young, you say what if you don't know. Send out to ref not from my door. Drugs get young, you say what if you don't know. The brother man used to tell a brother, one that hard drugs can kill a brother. Save your soul, one that malife, cause if you wound you, he got malife. I know that I'm tempted to light it, but I believe I can fight it. In name of Semogaba Rehab, I'm going there not just to please her, but to heal me and to help me. From a coding ref, I believe I can stop it for life.
I know go wait until he wants me. I know go wait until he buy me. I cannot put eye make you drop soon to me. Even though something must to kill a man. I cannot open eye, let them kill me. I go stand up, I go look for professional help.
I can stop it, I can leave it all.
I can't stop it, oh, I can't stop it, oh, I can't leave it, oh, I lie. Rock go shot in my life. I can't stop it, oh, if I sit down, they do nothing. I can't leave it, oh, I don't go wait until he wants me. I don't go wait until he buy me. I cannot put eye make you drop soon to me. Even though something must to kill a man. I cannot open eye, let them kill me. I go stand up, I go look for professional help.
I am tired already. My head is burn and I don't get it. I know one's got water, I go fight it. Colorado, Arizona, I can't leave it. As you see me so drama, download in my pocket. It killing me so and I know one kicky bucket. Just the other day, me got to socket. Now we think kill more trauma with in my pocket. My brother forget to drugs go shut in your life. Fight it, no they sit down, they do nothing. I cannot open eye, make it drugs to wound me. Even though something must to kill a man. I cannot open eye, make drugs kill me. I go stand up and go look for professional help.
Drugs get young, you say what if you don't know. Send out to ref not from my door. Drugs get young, you say what if you don't know. The brother man used to tell a brother, one that hard drugs can kill a brother. Save your soul, one that malife, cause if you wound you, he got malife. I know that I'm tempted to light it, but I believe I can fight it. In name of Semogaba Rehab, I'm going there not just to please her, but to heal me and to help me. From a coding ref, I believe I can stop it for life.
I don't go wait until he wants me. I don't go wait until he buy me. I cannot put eye make you drop soon to me. Even though something must to kill a man. I cannot open eye, let them kill me. I go stand up, I go look for professional help.
Northeast, north central, southeast, southwest, south of this great country. This is NDLA's Open Forum on X Space this Friday, the 26th of July, 2024. Would also like to recognize all our compatriots joining us from other parts of the world. I'm talking of those joining from Europe, America, Asia, Middle East, and even the rest of our continent, Africa here. This is the 105th edition of this wonderful conversation. And I'm your host, Femi Babafemi. We are live from the national headquarters of Nigeria's anti-narcotic agency, that is NDLA, located in the nation's federal capital territory, Abuja. As we often tell you every week, this platform provides an opportunity for us to share information, knowledge, and raise awareness about substance abuse and its devastating impact on human lives, public health, and indeed our environment. Would also like you to know that this platform serves as a channel for us to provide help to those struggling with substance abuse and who might need help. That is treatment. It is equally a means for us to update you about some of the activities of the agency, especially what we're doing to curb the scourge of substance abuse and illicit drug trafficking in our country. We also appreciate your feedback through your engagement on this platform, through your questions, and through your interventions. This helps us or enables us to continue to improve on what we do to serve you, our society, and even humanity better. Would also like to let you know that this conversation is recorded and is streamed live on our other social media handles, especially at NDLA01 on Facebook and at NDLA TV on YouTube. You can always go back to it, take a listen again, and even that is the recording, and even share with others. We have our guest already, that's our guest speaker for today, already well seated. But before I invite him, to make his presentation, let's quickly remind you of some of the activities of the agency this past week, and that we always do in our news highlight segment, which shall be taken again today like before by the duo of Netta and Comfort. Over to you guys. Let's get the update. Thank you.
Thank you, sir. Good day to everyone, and thank you for joining us on this week's X Space. My name is Netta Wedozier, and here are the NDLEA news highlights for the week. First, the headlines. Cocaine, loud consignment hidden in incense candles, ladies wear seized in Lagos. One-legged man, Beninese top police of arrest as NDLEA intercepts Nasarawa-bound drug loads meant for illegal miners in FCT. Frantic bids by drug syndicates to smuggle in and out of Nigeria, consignment of cocaine and loud, a synthetic strain of cannabis concealed in incense candles, game packs, dry hibiscus leaves, and ladies' native wears through the Murtala Mohammed International Airport MMIA, and some courier firms in Lagos have been swatted by operatives of the National Drug Law Enforcement Agency NDLEA, following the seizure of the illicit shipment and arrest of suspects linked to them. A businessman, Abdul Wahab Owolabi Alebiosu, was on Thursday, 18 July 2024, arrested at his Horizon Courts Lekki, Lagos residence after a consignment of 40 parcels of loud weighing 20.30 kilograms hidden in packs of chessboards, Scrabbles, checkers, and poker sets brought in from Canada on a British Airways flight was intercepted at the Sako import shed of the Lagos airport during a joint examination of the cargo with men of customs service. Some drug paraphernalia, such as weighing scale and cannabis potency test kits, while 4 vaping machines were recovered from his business premises on Admiralty Way, Lekki. A Meccano black truck with a registration number FST 657. recovered from a container marked MSDU 5656394 from Canada during a 100% search of the container at Tinkan Port in Lagos. Two suspects, Dada Kole and Alaba Oladewusi, have been arrested in connection with the seizure. Meanwhile, a 48-year-old one-legged man, Amadou Garba, was arrested by NDLEA operatives in his house at Yawuri Town, Kebbi State, with 6 bags of cannabis weighing 67 kilograms on Tuesday, 16 July. In Abuja, two suspects, 60-year-old Ademola Elisakin and 34-year-old Nuhu Friday Adamu, were arrested by NDLEA operatives on Monday, 15th July, with 30 kilograms of the same psychoactive substance along Kwali Gwagwalada Abuja Expressway on their way from Lagos to Nasarawa State. Elisakin claimed he procured the consignment from Ghana via Lagos with Kefi Nasarawa State as his final destination, where they were to supply illegal miners operating in the area. At least 305 blocks of cannabis weighing 152.5 kilograms were recovered from a suspect, Saleh Bukar, 39, who was arrested at Gaidam in Yobe State on Sunday, 14th July, while taking the consignment to Difa in Niger Republic. While a suspect, Aham Regal Chinemeze, 43, was nabbed on Thursday, 18th July, with 60 kilograms of same substance along Owerri Onitsha Expressway, Imo State. Adamu Abdullahi, 24, was arrested with 40.500 kilograms on Wednesday, 17th July, along Obajana Kaba Expressway, Kogi State. The consignment was recovered from him in a commercial bus coming from Lagos en route Kano. In Plateau State, a raid on the storehouse of a notorious drug dealer, Choji Giang, aka Pararam, who is currently at large, at Rukuba Road, Jos, led to the recovery of 34 bags of cannabis weighing 312 kilograms, while his manager, Kelvin Onwutali, 43, was arrested. Two suspects, Ifabiyi Johnson, 27, and Adeleke Musiliu, 54, were on Friday, 19th July, arrested with different strains of cannabis sativa weighing 30.4 kilograms during a raid in Oshogbo, Osun State. In Jigawa State, the trio of Tukur Yahaya, 55, Idris Haruna, 28, and Tainimu Omar, 29, were nabbed with 90 blocks of cannabis weighing 116.8 kilograms at Roni Junction, Kazaure local government area on Friday, 19th July, while on their way to supply the illicit drugs to their customers in Kazaure, Yankwashi, and Katsina states. Similarly, the duo of Ibrahim Abdul Kadir, 29, and Suleiman Muhammad, 22, were arrested with 336 bottles of codeine syrup at Amingo, Kaduna, while Awalu Hashimu, 35, was nabbed with 45 kilograms of cannabis along Zaria Kano Highway. Acting on credible intelligence, a team of NDLEA operatives shop opposite Benin Garage, Akure, Ondo State, where they recovered a white Toyota Hilux van with registration number EE328EKY, loaded with 652 parcels of cannabis weighing 685 kilograms. In Nasarawa State, 38 kilograms of the same psychoactive substance and a locally made AK-47 rifle were recovered from the home of a suspect, Christopher Ombogadu, 32, in Akwanga during a raid on Sunday, 14th July. In another report, NDLEA urges them to intensify the heat on drug cartels. After many years of wearing the toga of invincibility, the overall head of the Mushin Lagos drug cartel, 57-year-old Alhaji Suleiman Jimo, alias Oluwo Idiogede, popularly known as Temo, has been arrested by operatives of the National Drug Law Enforcement Agency (NDLEA) at his enclave after an initial resistance from him and his herd of hoodlums. In the last 2 years, the NDLEA had intercepted large consignments of illicit drugs worth billions of naira owned by Temo, but he has remained largely evasive, while a few encounters with him and his armed gangs in his Mushin enclave had resulted in gunfights. Some of the recent seizures of his shipment include a 14,524.8 kilograms of Ghana loud, a strong strain of cannabis sativa smuggled into Lagos from Ghana in 2 trucks and a J5 bus, intercepted at Ojuelegba area of Lagos in the early hours of Sunday, 28 January 2024. Two truckloads of the same substance weighing 8,852 kilograms intercepted at Eleko Beach, Lekki, Lagos on 4th May 2023, and 252 kilograms of loud seized from his enclave in Mushin on Wednesday, 26 July 2023. Indeed, in the last two encounters, his men engaged NDLEA operatives in gunfights. The drug kingpin was very notorious for always being on the move to evade arrest, but with persistence and determination of the agency, aided by modern tools and intelligence, the concerted effort to get him paid off at 10 a.m. on Monday, 22nd July 2024, when NDLEA surveillance teams on his trail tracked and pinned him down at Igbarere Street, Mushin. A reinforcement of about 100 operatives was immediately mobilized to the area while he was attempting to escape in a Mercedes-Benz SUV GLE 350 marked 01G 300G. His attempts to escape by mobilizing hoodlums to engage and distract the operatives, however, failed, after which he was overpowered and whisked away from the chaotic scene, while his men surrendered to the superior firepower of the anti-narcotic agents, who also succeeded in recovering the Mercedes-Benz SUV the suspect was found in. In his reaction to the arrest of Temo, Chairman Chief Executive Officer of NDLEA, Brigadier General Mohammed Bubamara, retired, commended the officers and men of the Lagos State Command, Special Monitoring Task Force, and other formations tasked with the assignment of getting Temo arrested for their resilience, vigilance, and professionalism. He urged them to intensify the heat on all drug cartels wherever they are located. I am particularly delighted because the arrest was eventually effected in his enclave without any casualty, despite the attack on our men. This is therefore a clear message to others still involved in this criminal trade of illicit drugs that if they don't opt out now, we'll get them because we're just steps away from their doorsteps, and more importantly, they can only run, they can't hide forever, Mara stated. That's 18 arrests and seizures. Now, here are some of the wider activities across the country for the week. Over to you, Comfort.
Thank you, Netta. My name is Comfort Folorenshaw, and here are some of the wider activities across the country for the week. The commencement of the War Against Drug Abuse Wider Social Advocacy Initiative by the National Drug Law Enforcement Agency, NDLEA, came on the heels of the need to address the problem of substance abuse in our communities. This comprehensive awareness program happened simultaneously across all the parts of the country as command of the agency spread information and empower people to make informed choices about their health and safety, especially regarding drug use. The advocacy program are tailored to fit target audiences in schools, worship places, workplaces, and even communities. On Tuesday, 17 July 2024, the Osun State Command delivered a wider advocacy lecture to students and staff Ede, while the Yobe State Command took its wider sensitization lecture to New Foundation Secondary School, Damaturu, on Wednesday, 17 July. The Ogun State Command followed suit with a wider sensitization lecture to students and staff of Community High School Senior, Owode. Also on the same day, students and staff of Federal Science and Technical College, Dai, received a similar lecture from the Katsina State Command. On Thursday, 18 July, the Anambra State Command presented a wider enlightenment lecture to students and teachers of Water Eze Secondary School, Upo, Dunokofia, while the Akwa Ibom State Command also gave a wider sensitization lecture to students and teachers of Goretti Secondary Commercial School, Ikot, Ipene. Intensifying the wider campaigns for the week were the Enugu State Command and the Semi-Special Area Command, which reached out to students and staff of Urban Secondary School, Ugwo, and Ilogbo Senior Secondary School, Badagry, Lagos, respectively. Friday, 19 July, concluded the activities for the week with wider lectures delivered to pupils, students, and staff of several schools. The Benue State Command delivered a sensitization lecture to pupils and staff of Merit Kids Academy, Ugbo Gwen, West Local Government Area. The Niger State Command to students and teachers of Emir Salihu Tanko Day Secondary School, Kangara, and the Ekiti State Command to the students and teachers and staff of Ikole City College, Ikole Ekiti. That's the update for this week. My name is Comfort, and I hand you over to our host, Mr. Femi Babafemi.
All right, thank you very much, Netta and Comfort there. Welcome back from the news highlight segment. Now let's remind ourselves about some of the rules of our engagement on this platform. Please note that when you are approved to be on the speaker's corner, let's ensure that we remain muted until after our guest presentation. I will start to invite individuals to unmute themselves to make their contributions or ask questions as the case may be, and this we expect to be done in few seconds. Besides that, we also don't encourage unauthorized interruption that may lead us to remove you from to take the mic from you or remove you from the speaker's corner. So please let's ensure that we are well guided so that we all can enjoy the conversation and enjoy the presentation, especially by our guest today. Okay, before I introduce our guest who is already well seated, I'd like to tell us about the NDLA's call center, where we have a team of experts, including counselors, clinical psychologists, psychotherapists, and psychiatric doctors, working 24/7 to provide you psychosocial support services, teletherapy, through our toll-free helpline 0800 1020 3040. You can sit in the comfort of your home, especially those who are afraid of being judged or being stigmatized without absolutely any fear of this. You can call this toll-free helpline for yourself, your friend, or your family member and get the needed support. This service can actually also be provided in any of the three major Nigerian languages apart from English, Pidgin. We also support you in outside have an excuse not to seek support or not to seek for treatment or counseling anytime we have issues of substance abuse, whether with ourselves or with our neighbors or our friends or family members. Please let's take advantage of this service to ensure that we get the needed support. We'd also like to tell you briefly about our Save Our Families Solve campaign, which is driving advocacy for drug testing. The agency has at the moment thousands of test kits that can discover as many as 15 substances available on, all our commands across the country and some other designated centers where we encourage parents, schools, and institutions to get these test kits so that they can start using them in their homes. Our toll-free helpline is available for you at the end of the test to seek support, whatever you discover to be the result of the test. This is for early detection and also provide support services or treatment early before the situation gets out of hand. That's for that. Now let's come to our guest today. After that, I'll have to recognize quite a number of our compatriots on the platform joining us from across the world. But quickly, let me tell you about Dr. Allen Aloge, who would be speaking to us today on the challenge of medical conditions and coping with the pressure of drug abuse. This is indeed a huge challenge for those who indeed genuinely treating some medical conditions, and so they need some of these pharmaceutical opioids to treat this. But then just a thin line between the use of these pharmaceutical opioids and the abuse of these opioids. All of that will be broken down for us by our guest speaker, and then we'll know how some of the skills to cope with this kind of pressure, or how to avoid falling into dependence on these opioids. Now, Allen Aluge is a medical doctor with diverse background in health financing, insurance, and narcotics prevention. With an MD from the defunct Luhansk State Medical University in Ukraine. Oh, okay. Now I know Allen is from that region. Okay, Allen has a strong interest in drug use prevention and identification of illicit synthetic narcotics. He is certified as a clandestine lab operative under the United States Justice Department. Additionally, he is an alumnus of the International Law Enforcement Agency Regional Training Command. Besides that, his expertise includes identifying clandestine labs, understanding threats in synthetic narcotics, and educating the public on preventing substance use among youths. With a blend of medical knowledge, leadership skills, and a passion for public health, he is dedicated to making a significant impact in healthcare delivery and prevention of drug abuse in our society. Dr. Allen currently works at the Directorate of Medical Services and the NDLEA headquarters in Abuja here. Please join me in welcoming Dr. Allen Aluga as I invite him to unmute himself while we listen to him for the next 30 minutes thereabout on discussing the topic for today, that is the challenge of medical conditions and coping with the pressure of drug abuse. Please go ahead, Allen, with your presentation. Please go ahead.
Thank you very much, sir. Director of Media Advocacy, Mr. Babafemi. First of all, I would like to use this opportunity to thank everyone on the space today who is attending. I'm made aware that we have some medical experts and psychologists. It will be a pleasure to be part of an interactive session with you on this topic. As I delve into the topic, I had an observation. The topic, it seems to be fluctuating two topics, but I'm definitely going to find a way to harmonize it. It says the challenges of mental condition and coping with drug abuse. I'll speak on that because that's very important. I also speak on the challenges of medical conditions generally and coping with drug abuse and the nexus.
Alan, don't mind whoever wrote mental. There's actually medical conditions. I don't know who wrote mental here. I think it's on this paper. Apply actually stays medical. Please go ahead. Thank you.
Okay, thank you very much, sir. Anyway, she didn't make a mistake because she's hitting one of the points that is heavily affected or probably most neglected when it comes to medical conditions that can lead to drug dependency or codependency. So I'll start by talking about medical conditions generally and medical challenges. In Africa here and globally around the world, we have different medical challenges. We have occupational health challenges. We have age-related health challenges. We have health challenges as a result of infectious disease. We have gender-related health challenges. That's why we need special psychologists. That's why we also have many reasons why females or the female gender has specific needs that are tailored to specific consultants to manage. We also have genetic-related health challenges like your sickle cell, like your diabetes, type 1, etc. The list is very long and cannot be exhausted. We also have concomitant health challenges. Sometimes you have more than one health challenge existing in one individual. So the truth of the matter is we have so many different health challenges. But it's very important that at the end of this discussion, we look at the risks, some of the risks that can associate some of these medical health challenges. Sometimes, taking mental health challenge for an example, we found out that most countries, statistically, around the world, we have 970 million people as at 2020 living with one mental disorder or mental illness. When we came to Nigeria, we found out that we have 60 million people. And by 60 million people, it means 30% of the population of Nigeria is living with one mental disorder or the other. That was by Dr. Taiwo Obido, the Association of Psychiatrists, the president of the Association of Psychiatrists Nigeria. According to WHO says 20% of the population of Nigeria, which is about 40 million, is living with one mental disorder or a combination of both. And the painful part is that less than 10% of these people living with mental health disorder would have access to a professional for assistance. As of 2020, according to Lancet Global Health, Nigeria faces a mental health emergency. It also says that we have fewer than 300 psychiatrists in Nigeria. So it means that the challenges we have are not commensurate to the help that we need to curb the surge of mental health illness. It talks about some of the factors that can lead to mental disorder, because I must first delineate between a mental illness and a mental disorder. Mental illness, as opposed to what we called lunacy from the 1916, when we first had the conversation about mental illness and the country had put in measures and passed the first bill, before 1958, when we now had a bill that could actually understand or enforce how a Nigerian living with mental illness could be treated in a humane environment, and also considering the rights of a Nigerian living with mental illness. It also considered his rights, his ability to have a job, his ability to have good housing, his ability to not be discriminated, etc. So over time, mental illness has been a subject of discrimination and a topic that has been pushed under the table for a very long time. So we're going to have to look at mental illness as my focal point for this particular conversation. So I'll delve into it. What is a mental disorder, or what is mental illness? Some people think it has to do with madness or lunacy generally. But I'll tell you that like significant disturbance in an individual's cognition, emotion, regulation, or behavior. It is usually associated with stress or impairment in important areas of functioning, and there are many different types of mental disorders. In 2019, 1 in every 8 people around the world were living with a mental disorder, with anxiety and depressive disorders. In 2020, the number of people living with anxiety and depression disorders rose significantly because of the COVID-19 pandemic. This is not surprising because there was a lot of poverty at the period. There were a lot of restrictions, access to funding, access to healthcare, most factors that are responsible for depression and frustration could have easily increased the numbers of people living with mental health disorder. So I'm going to give some examples. Anxiety disorder. We have 301 million people living with anxiety disorder, and amongst them, 58 million are children and adolescents. Anxiety disorders are usually characterized by fear, and there are several kinds of anxiety disorders. We look at depression. In 2019, 280 million people were living with depression, including 23 million children and adolescents. Depression is different from the usual mood fluctuations and short-lived emotion response challenges in everyday life. During a depressive episode, a person experiences depressed mood, feeling sad, irritable, empty, low self-esteem, loss of pleasure or interest in activities. Depression is one of the major causes of suicide and is tagged as a serious risk for specialists and professionals who handle mental health care. Bipolar disorder. In 2019, 40 million people were said to have experienced bipolar disorder. And people with bipolar disorder usually have depressive episodes that can be short-lived, and they might also have maniac episodes, which is like an extreme opposite. So sometimes they could be very happy, and sometimes they could be very sad. Maniac symptoms may include euphoria or irritability, etc. Sometimes you see these people when they're in their maniac phases have attributes of talkativeness, racing thoughts, increased self-esteem, decreased need for sleep. Yet, effective treatment options exist, including psychoeducation, reduction of stress, and strengthening of social function. We have PTSD. PTSD is very prevalent amongst... Sorry, please, can you hear me?
Yeah, very loud and clear. Please go ahead.
Okay, thank you. The prevalence of PTSD and other mental disorder is high in conflicted areas. So areas where you have conflicts, areas where you have war, insecurity, etc., where you have soldiers fighting, you can have a lot of cases of PTSD, and that is very, very, very common in Africa right now. Schizophrenia. This affects approximately 24 million people, or 1 in 300 people worldwide. People with schizophrenia have a life expectancy of 10 to 20 years below that of the general population, according to WHO. Yet a range of effective treatment options exists, including medications, psychoeducations, family interventions, and psychosocial rehabilitations. This, amongst numerous other mental disorders, can be discussed. Now, we had to look at some of the societal factors and the risk factors that could push an individual into developing mental disorders. We looked at poverty, violence, disability, inequality. And according to the WHO Comprehensive Mental Health Action Plan 2013 to 2030, it recognizes the essential role of mental health in achieving general health care for people. We actually have a serious problem here from all the statistics that have been mentioned. And one of the issues we have is managing these conditions. Before we think about managing these conditions, we also need more professionals who are experts in the field to be able to help us manage this particular situation. And we are talking about psychiatrists, neuropsychiatrists, psychologists, counselors, and all stakeholders that are involved in ensuring that the system works properly. So we discussed the health management of these individuals. People living with mental health are very vulnerable. People living with mental health disorder are very vulnerable people emotionally. So naturally, they require specialized care. They do not require general practitioners. They do not require being treated by traditional herbal doctors, etc. They require specialized care between neuropsychiatrists, psychologists, and counselors. The reason why is very simple. For most of these cases, they would require legally treatment with prescribed opioids, stimulants, etc. A neuropsychiatrist is in the best position to actually manage such people with mental disorder. In the absence of where you have fewer numbers of psychiatrists attending to these people, they will end up falling into the wrong hands where they might be treated by general practitioners, treated over the counter, and the specialists are the ones that are able to tailor up a program that can actually manage the addiction that might set in due to the use of some of these medications. So I'm going to be calling out some of these medications so that we understand the severity of what we're talking about and how quick it is for a patient to get addicted in the process of treatment. For depression, serotonin reuptake inhibitors like fluoxetine, citalopram have been used. And studies have shown that these medications, over time, without proper management, can lead to addiction. The use of amphetamines in people that have attention deficit disorder, ADHD, is a very stimulant. In fact, amphetamines today in the market have
Something is wrong with your system there. You are not speaking to, we are not hearing you. You are very faint. Maybe. Yeah, Alan, can you hear me?
Yes, sir, I can hear you.
Okay, you are better now.
Can you hear me now better, sir?
Yeah, you are better now. Please go ahead.
Okay, sir. So I said some of the drugs that we use for the treatment of ADHD, which include amphetamines and methylphenidates, are very potent psychotropic substances. They are stimulants and they are highly addictive. Without an expert or a specialist like a psychiatrist, it will be very difficult for a patient to be properly managed throughout the stage of depression.
You are going off your system. You are going off your, don't know, whatever system you are using. You are skipping off it.
Okay, sorry, sir. Better now? Am I more audible?
Yes, better now.
Okay. I said, so we're going to look at coping from 2 points of view. Coping for the victim who is probably going to be or might be at risk of addiction as a result of the use of some of these substances in treatment. And also, we're going to look at coping from the point of society, who has to be a major influencer in guiding and helping such people during these phases of addiction. The society involves the government, it involves the stakeholders like the religious leaders, it involves family. Family is a very, very strong pillar when it comes to helping with coping mechanisms for some of these people. So coping, we have two types of coping mechanisms. We have the unhealthy coping mechanisms and we have the healthy coping mechanisms. Unhealthy coping mechanisms are involuntary reactions that we develop or that individuals develop to manage a situation. Sometimes it could be stress, sometimes it could be an irrational emotional response to a situation as an idea, as an avenue to deflect from the current situation. These are unhealthy examples of unhealthy coping mechanisms. Coping mechanisms that are healthy are strategically organized by stakeholders, and these are not limited to addiction therapy sessions. Support groups. When you have support groups, you have individuals who come together and, are supported by a set of people who would include experts, who would include stakeholders. We have group therapy sessions. Group therapy sessions will include a couple of individuals who might be suffering from similar situations and have an opportunity to share their experiences so that they can find a way forward. From comfortability and the idea that confidentiality is maintained as a result of their case, which is usually discriminated upon, such victims are able to share more and express themselves better. And opening up is one of the first steps to actually getting yourself rehabilitated for people who are affected. Another coping mechanism could be distracting yourself from triggers, and triggers are usually different things. A trigger for an individual could be remembering a particular event, during the time when he was actually getting treatment on some of these opioids, because sometimes these opioids, the victims have a feel good sensation. They have a feel good sensation. Serotonin is filled up in the brain and there's excitement and euphoria. So most times when they find themselves passing through the environment or seeing something that reminds them of that particular time, they have the urge to want to use some of these substances. So a good coping mechanism will be distracting yourself from triggers with music, distracting yourself with getting a good skill like a handwork, watching a movie, entertaining yourself, putting yourself on a good diet, replacing some of these addictions with food, because food is one of the basic things that naturally helps the body to function properly. Engaging in creative activities. Reconstruction of a new version of yourself through creating and utilizing a journal. Sometimes our counselors will ask some of these victims to take a book, get to a quiet place, and reflect on themselves and write about how they would like to perceive themselves or how they would like to be different from their current situation. And by the time they write these things, they go through them, they read them, reflect on them. It also helps to mold the new personality that they're trying to have. I'm going to say that mental health disorder is usually behavioral. It affects the emotions, it affects the perception of the individual. So they have a false perception. And for this reason, they are very vulnerable and they require people who can actually understand or get through to them. So it is something that requires the specialists to be trained, retrained with updates on the emerging trends, emerging patterns in managing and communicating with people who have such issues. Now I'm also going to talk about people living with sickle cell disease. Sickle cell disease is very common in Africa. Globally, we have about 80 million people living with sickle cell disease, and the epicenter of sickle cell disease is in Africa. And in Nigeria, we have, according to the WHO, 1 out of every 4 individuals in sub-Saharan Nigeria may be living with sickle cell disease. This disease, as many people know, puts a constraint on financial resources, puts a constraint on the living opportunities for such individuals and standard of living generally. That is why, as professionals in the field, managing sickle cell patients is quite emotional. They have certain complications known as crisis, vaso-occlusive crisis, acute chest syndrome. And for the benefit of our people who are non-medical, I'm trying as much as possible to break down some of these terms, so I don't want to use heavy terms so that everybody can be carried along. These people are subjected to a lot of pain when they have these complications. When they go to hospitals, we find out that the regular painkillers that can be used in managing headaches and inflammations no longer work. They need to be stepped up to higher pain medications, for which some could be opioids, some could be narcotic analgesics, and some of them have high addictive potency. How do you manage such patients? This has become a challenge for us. So we try to look at the solutions. What are the solutions in place? Who are the stakeholders? The first thing we have to look at is the health sector. The health sector, which consists of medical professionals, health management systems, the Ministry of Health, have to look for a way amongst all the programs that they have to see how they can improve the health management of sickle cell people. As at 2022, the sickle cell bill has still not passed through the third reading at the National Assembly. This is something that we have to find a way to talk to our leaders to help us, because these people are very vulnerable people. Because we have a limited number of neuropsychiatrists, because we have a limited number of anesthesiologists, we now find other care providers also taking the front stage in managing such people. They need to be trained. We need to improve the number of specialists that we have in the field so that these people can be managed professionally. That way they wouldn't be managed and abandoned. There is someone that will follow up their management and ensure that the possibilities of addiction are reduced through strategic planning of regimen for treatment. We also have to look at some of the challenges surrounding coping mechanisms. Yes, it's easy for us to talk about coping mechanisms because theoretically we have all the guidelines, but there are also some environmental factors that can affect the ability of an individual to cope. For example, when our patients are not able to get the medications they need from the right professionals and the right sources, they are easily able to turn to other forms of synthetic narcotic drugs that are sold on the black market for abuse. I'm going to use a personal experience. While I did some voluntary work with Sickle Cell Aid Foundation about 4 years ago, we noticed that we were getting calls for blood transfusion, for requests for blood. Some people will call you and tell you, my child is a sickle cell patient and it's 12 o'clock and we can't get to any hospital and she's in crisis. And you can hear the child screaming because the pain is very terrible. So they do need these medications. But because there is no professional very close by, because some of these people don't have access to funding, because the health insurance sector is not covering some of these particular high utilization medical challenges, these people find themselves on their own and have the opportunity to get themselves alternatives which may be available on the black market. This sincerely is a problem. We also need a situation where prescriptions for certain medications should be provided only by the specialists. It's easy for a general practitioner to run into an individual who he suspects has depression, and he knows the medications to give. And a general practitioner would write a prescription, an opioid prescription that should be prescribed by a neuropsychiatrist, and the pharmacies will provide such medications. We need more regulation. We need more regulation so that we can have a holistic approach to managing people with these medical challenges and reducing addiction. Some coping mechanisms that we have found out, some negative coping mechanisms that we have found out amongst people living with medical conditions because they have not been properly counseled. Can you hear me, sir?
Yes, but your time is running out. You barely have 3 minutes more.
Okay, I'll be summarizing, sir. So one of the challenges that we've also found out for people on coping, negative coping mechanisms is on the field, we have been able to elicit that people who did not have access to proper medical care will self-medicate. They will self-medicate. People who have serious health challenges, who do not have finance, will turn to quacks. And we have an iatrogenic way of getting people addicted. When you meet the wrong medical personnel, if he's not a professional, if he's not licensed, if he's a quack, sometimes he might prescribe drugs for you without counseling, without telling you about the effects, the adverse effects, how you would feel, and guide you so that when that is done, you would be able to come out of that feeling. We have people that just put you on these medications and then you're allowed to figure it out by yourself and get into dependency. So generally, I'd like to leave the floor open for interaction so that some of the professionals and stakeholders will be able to also throw some more light on this very important topic that we have today. Thank you very much, sir.
All right, thank you very much there, Alan, for speaking with us. You may have to mute yourself now so that there is no interruption coming from your end. All right, once again, we'd like to appreciate Dr. Alan Aluge for his presentation. That's a brilliant one. Quite getting some reactions in our DM to you, but I'll come to read some of those. But quickly, let me appreciate and acknowledge some of our compatriots joining us from across the world. First, I've seen Dr. Abdullahi. Dr. Abdullahi, quite a while. I know you must have been busy with some research work. I've been told at a point. Welcome back to the space. Thank you very much, Dr. Abdullahi from the Ahmadu Bello University Teaching Hospital Zaria. We also have Baba Gana Gubio. Thank you, Baba Gana. I've also seen TK Tinu Idowu is joining us from Maryland, US. Thank you very much, TK. I also have Dr. Jonah Kolo. Dr. Jonah Kolo is a senior officer of the agency, actually the coordinator of Alternative Development Program. I also have Ayuba Sunday. Thank you, Ayuba. We also have Diva Dushi. Diva Dushi, thank you. Bonded Brothers, thank you. Ino Victoria, my colleague in Lagos, Rita Okwere. Honorable Ajala, thank you. Vicky Place. A regular member of the platform, John Ogunjimi. Thank you, John. Arewa Poet. Thank you, Arewa Poet. We also have a senior member of the platform, Dr. Asiya Adamubi. Thank you very much, Dr. Asiya. Dr. Molara. Dr. Molara also joins us from Kaduna. Dr. Molara was recently a guest on this space. Thank you. Also, we have Dr. Akinola Adekpetun. Thank you, Dr. Akinola. We also have another doctor, this time community psychologist, Dr. Loretta Ekanem. Loretta joins us from Chicago, Illinois. Thank you, Loretta. Favor Namgwa. Pardon me, but I know I got the favor right, but the Namgwa, I don't know if I got that right. Thank you for joining us. Mohammed Bafo, another regular member of this platform. Thank you, Okikiola, your perfume plug. Thank you, Okikiola. Sergeant Shegzi, Deja Vu, Felix Goodluck, Yero Ahmed. Yero Ahmed is another senior officer of the agency. Thank you, Yero. We have Suleiman. Suleiman is a regular member of the platform. We also have Dr. Kemi Olunloyo. Dr. Kemi Olunloyo is already seated in the speaker's corner. We also have Blank Mind. I have seen Blank Mind there. Let me quickly read some Blank Mind. Let me quickly read some comments or questions from our DM. Alan, you have to get your barrel and pen, your pen and paper so that you may have to jot down some questions. Okay, say no to hard drugs. I'm not joining that. Smart Ogbese Junior. Thank you, Smart. Okay, Deja Vu is saying, Dr. West, I would appreciate you break things down so we all understand you. I think he tried to do that, breaking things down, some of those terminologies, some of those terms. Thank you very much, Deja Vu. Austin Bello, lack of proper diagnosis and medical professional in our hospitals. Yeah, I'm sure Dr. Allen mentioned that. Lack of enough professionals as one of the constitutive factors. How many hospitals in Nigeria have this is from Latif Rashid Olaleko. How many hospitals in Nigeria have neuropsychiatrists? Only Dr. Abdullahi can answer that one because he is one. Okay, let's get to the conversation proper now. I have that just some comments. I skipped the questions. Okay, let's have the first intervention from Dr. Kemi. Dr. Kemi, please go ahead with your intervention. Dr. Kemi Oluloyo, are you here?
Yeah, I'm here.
Okay.
I heard everything that Dr. West said, and he made a great presentation. Quite fantastic there.
Why are you sounding sleepy? You are sounding sleepy.
What I'm going through over here, the wind is high and we're losing Wi-Fi. I was teaching a class for free monetization for Facebook for Nigerians, 4 hours. We're on hour number 5, so I had to leave after the Wi-Fi cut off. It's back, and then I'm here, and I'll be back there 5 Nigerian time. You know, when I finish here. So I'm so tired. 4 hours. I'm trying to get people to not protest and to just make money on Facebook. Let's go. So everybody can do their own. So I'm going back to the class like when I finish here. Okay, Dr. West has really terrific points, and I'm going to use myself. Dr. West, I want you to please listen, because right now I'm your patient. I'm going to use myself as an example. I'm a clinical and retail pharmacist of 35 years, 1988. But I dispensed these drugs in America most of my years there. I have never practiced pharmacy in Nigeria, but being a pharmacist in the US, I do go to different pharmacies in Nigeria and see how pharmacies operate. Now, I won't mention the name, but there's a pharmacy near my house in Ibadan when I was in Ibadan. The owner of that drugstore, I looked at the dynamics of how they run the pharmacies, because a lot of times in Nigeria, there's no pharmacist there. It's the pharmacy techs and, medical personnel that are doing all this work, which you cannot do in America. It has to be a registered pharmacist and the technicians. If the pharmacist doesn't show up, they can't open the pharmacy. Now, that person near my house in Ibadan, I covered that pharmacy a few times for her. She wanted to travel. She is the pharmacist, and she's never really there because it's really a supermarket and pharmacy, so she put people there. But when she was traveling, she had me come in and be the one in the back in case people have questions, counseling and all. So I've seen the tramadols. I've seen everything. Now, when I went to Ghana, okay, and I'm going to say this sincerely because it is what it is, Dr. West. I am now your patient, and you are a doctor in Nigeria or Ghana. I am in pain. And in real life, I had foot surgery. And after the surgery, I had an accident on the very same foot, and I had to have the surgery again. And Doran Hospital in Ajah did the surgery twice. They did a fantastic job. You might know Dr. Ni Medubi. He's the foot doctor that does all the leg surgeries. Now, after the second surgery, I developed pain, serious pain, that when we were in Ghana in October, the pain caught me. It was so bad. So they sent me for an MRI, and I had an MRI, and I also had a Doppler ultrasound. During the Doppler ultrasound, the doctor in Ghana discovered that there is a nerve that's partially damaged that was coming from my back through my right leg all the way to the foot. So all I felt was numbness all the time, neuropathy, and pain, and fire in my foot, fiery feelings. So that doctor and I looked at him. It was a female. She looked at me and said, "Have you ever had a back injury?" And I said, "How did you know?" She's a doctor. I said, "What school did you go to?" University of Kumasi. They taught you well. I did have a back injury in 2005 in America, and I had an MRI. She said, "Can I see that MRI? Do you know where I can see it?" I said, "Oh my God, it's in a huge envelope in my house in Ibadan." You can't see right now, but she said you need a new MRI because the problem in your foot is really coming from your back. Now, the surgery, they went in there. So you're now seeing this whole thing with, with pain, okay, because they went in there. But in this Doppler ultrasound, something is going on in your back that's going through your bum to your thighs all the way. So, Dr. West, she told me to go to the pharmacy and get hydrochlorothiazide because my foot was swelling. And she gave me that tramadol 37.5 slash paracetamol 325. Okay. When I took the pain medicine, I mean, the pain was gone. I had no euphoria, nothing. So, almost 8 months since we left Ghana, I'm back and I'm getting just this restless leg syndrome. So I was given Pregolin yesterday. You know, is how do you pronounce it? I'm a pharmacist, and it's like, Pregolin. Dr. West, can you hear me?
Yes, I can hear you.
Oh, you know
Is it
Pregolin, right?
or pregabalin? Pregabalin or
Pregabalin.
Okay.
That's it. And so they gave me Pregabalin yesterday. American doctor. He told me that he's going to use it. When I looked at it, it says gabapentin was in there. And I said, okay, I don't want you to get addicted to anything. I said, I'm not even addicted to anything. I mean, I showed him the 2 tablets left from October in Ghana. And he was like, oh, this is really good. That's what I was talking about last week, Mr. Babafemi, that in Nigeria, we have 50 milligram tramadol, but it can even be lower in a combo. So, Dr. West, what happened is pregabalin was given to me yesterday. I've only taken 2 doses. And honest to God, I'm not in pain anymore. My leg is not restless. There's no fiery feeling. There's no pain. And there's no, that whole neuropathy thing. Everything just went. So I said to myself, when I get to the spaces today, because this topic is about the challenges of medical condition and coping with drug abuse, why are doctors not using things like this, like pregabalin, more? Because this thing has a gabapentin-like thing, and it's actually working in the brain and sending these signals to these nerves and stuff to just calm them down. Why are we not using those for people who have conditions like this? Why must it always be a narcotic? So that's what I want to say, Dr. West. Should we use more medications like pregabalin? And I know Celebrex was part of it, but they took Celebrex off the market because of the other things, side effects that happen. But why are doctors in Nigeria using so much controlled substances? Like what pharmacist Aboma said, somebody had a headache, you gave them tramadol, now they're in 2,000 milligrams and they're addicted and they can't control it anymore. And they're now narcotic tolerant. And also things like benzodiazepines, to use for muscle relaxants. There are other things, antidepressant. If someone has anxiety, why are we giving them all these, benzodiazepine for anxiety all the time? We can put them on antidepressants. I don't see that in Nigeria. What is the problem? Is it because of the cost of the drugs or availability? We don't even have ordinary naloxone for drug addicts on the street. So my question to you, Dr. West, is why are we not using non-narcotic drugs more in Nigeria? I know there's not a lot of neuropsychiatrists, but we should really look at that area. So that's my big question for you. Thank you, sir.
Thank you very much, Dr. Kemi Olunloyo. I'm very happy with this question because it's a practical question that you can relate to, and I'll try and answer it as practically as possible. So, yes, we do use some of these drugs in Nigeria, but it depends on the professional. It depends on the patient. So I'll start by saying, as a pharmacist, you know that every patient is different. We have different body mechanisms. So the same drugs might react differently with different individuals. That's talking about pharmacodynamics and pharmacokinetics. Now, putting that aside, from your own case, it's obvious that there was some nerve injury or nerve degeneration, depending on how it was translated. And the doctor obviously knew that wherever there is a nerve injury, there's a possible inflammation. The possibility that fluid might accumulate around that particular space, irritating the nerve, is what he deciphered as the problem. So by giving you hydrochlorothiazide, which is a diuretic, his intention as a doctor, because doctors, there's no hard and fast route, even though we have some things specific. As a physician, you have to play around with medications. He gave you that to be able to challenge your kidneys, to force that fluid out of that space, get it out of your system. And once the fluid was out of the nerve space, you had some peace. Another doctor probably might have thought that, okay, she's having some pain. Let me just block the pain. Don't treat the problem, treat the symptom. So you have a lot of doctors who treat symptomatically, and you have a lot of doctors who treat curatively. Now, for you to treat curatively, you have to be in a system, a health system that gives you access to investigations, equipment that you require to make this proper diagnosis so you don't end up having misdiagnosis. You also need to have professionals who have been trained. While I was in Ukraine, we had a specific course called pain management. We're taught how to handle pain as a subject, different kinds of pain. In another country, the curriculum could be different and the doctor could act differently. So yes, we do prescribe these drugs. I'm sure if most of the elderly people, like I was talking about age-related medical conditions, you see people coming down with spinal cord compression, disc compression, degenerative spinal diseases, occupational hazards. When you have a bad chair in your office and, you have a sedentary lifestyle, after some time, you see that you have some disc degeneration or some spinal compression. Most doctors, if you go to a general practitioner, he might want to give you some, because patients will also come and complain that, oh, the pain is so much, I can't sleep, I can't, hysterical. And if you're not able as a doctor to assess your patient from the moment he walks in to when he sits down and determine if he's being hysterical, if he's overestimating the kind of pain he has, etc., you might fall for some of these traps. But you see most consultants here, they use things like Sidalud. And if you check, Sidalud actually works. And what does Sidalud contain? Sidalud is a tinazidine. You understand? It's a tinazidine group. You see it like Zanaflex. It's an alpha-2 adrenergic receptor agonist. So what do they do there? They make sure that the adrenergic receptors are, acting more. They're not blocking it so that the person can have some form of peace. Okay. In some other cases, you see a patient, like I'm not going to use you as an example now. If you have a patient if you have a patient who probably traveled to a foreign country and comes to Nigeria, you will find out that what we need in our systems are more of regulations. I don't want to be controversial, but pharmaceuticals is a business. And there must be regulation in any form of a business to protect the lives and the health of the individuals in that country. Education and
very
exposure.
important. Yeah, Dr. West, let me hold that thought. Let me interrupt you real briefly. That is very important because the pharmacist that treated me in Ghana, okay, now remember I said I went to an MRI there in October while I was there. I went to a doctor who sent me to the MRI and the pharmacy. That particular pharmacist, I messaged her on WhatsApp yesterday and I said, I told the doctor here that I'm on Sinalud, which is what they gave me in Ghana. But that stuff made me so drowsy and it didn't work as much as I wanted it to work, tizanidine. So when I told this doctor here in the States and I said, this is what they gave me, he now said, okay, I'm going to put you on pregabalin and blah, blah, blah. So I now messaged that pharmacist and I told her, I said, guess what they gave me? He said, oh, we carry it. We actually carry it. So when you come back to Ghana next and you need it, you can just come in and buy it. I said, did you say come in and buy it? So I don't need a prescription. She said, yes. Now, this is the situation in Nigeria and many African countries and Mexico. We don't get prescriptions to get these drugs. We are buying them with no regulation. You see what I'm saying, Dr. West? So it presents a problem. Because, I mean, pregabalin, when I was looking at the write-up and everything, this is something working in the brain and sending signals to nerves and stuff. Somebody needs to monitor all this stuff because the patient in Africa, the patient will not go back to the doctor and be buying it and buying it and buying it until you get to the side effect profile. That's what I wanted to say.
So thank you very much, madam. You're very right, and that opens up a channel for regulation because the pharmacies are regulated, but they might be in a peculiar country like Nigeria, where we are trying to get things right, the stakeholders should be given more powers. For example, if you look at the drug demand reduction as a pillar under the National Drug Control Master Plan Act, you will see the stakeholders are very clearly written out there. You know, the Federal Ministry of Health, the National Drug Law Enforcement Agency. So these agencies who are committed to protecting health care, the health of individuals, and ensuring that there is a drug demand reduction should make sure that they get the powers to regulate the activities of some of these pharmacies. It will surprise you that if you walk into some of these pharmacies, you will find out that their poison boxes are not accounted for. You will find out that you can walk in there as a casual you know, under the guise of a medical practitioner or something, and write a prescription that probably might not be properly audited, because I see some prescriptions and I wonder why certain people are not called back to be investigated. You see a doctor, you know, even the way we write prescriptions in Nigeria, there has to be more training. You write a prescription, you need to write what you're giving the prescription for, so that the pharmacist will also have an input. A doctor can also make a mistake. A pharmacist should be able to say, this drug doesn't come in this quantity, it comes in this quantity. But you know, somebody will just put one tab. He's not saying whether it's 500 milligrams or 200 milligrams, but because the pharmaceutical industry is interested in selling.
We're selling drugs.
We're selling drugs, so we need to regulate that.
Selling drugs. That's what it is. Dr. West, did you go to school in Ukraine?
Yes, madam, I did.
That's, you came late, Dr. Kemi. That's why you didn't hear that part when I read a bit of it.
Anyone that goes to medical school in Ukraine, oh God, that country has the best schooling.
All right, Dr. Kemi, you can still go back there and take some after the war. After the war, there you can still go back
the war paid me. The war paid me because the schooling in Ukraine is tops. It's really tops, and that University of Kumasi. Dr. West, thank you. I'm done. We need the regulation. NAFDAC needs to do more, and we really need the regulation, and we need a computerized system in America. You know the computerized system we use. Yeah.
Thank you. We're getting there. We're moving by the day, and don't forget that we have a new pharmacy act that really Stevens
you still need help.
Yeah, so all of these things are coming into place. So,
Dr. West, please send me your contact in the DM. Thank you, sir.
Okay, thank you, Dr. Kemi. Okay, quickly, let's take this one so that it's not between Dr. Kemi and Dr. Allen today. Okay, quickly, let's take this one from Ediga. Ediga is asking, what are effective coping mechanisms for dealing with a terminal illness diagnosis? This person is, I know you've talked about coping mechanisms for some issues, but this one is, it's laying emphasis on terminal illness diagnosis. Two, the second part of the question is, how can individuals cope with the guilt and shame associated with past drug abuse? Yeah, please go ahead.
Okay, thank you very much. That's a very, very, very interesting question. Very good question. I'll start with coping with terminal diseases. We have a couple of terminal diseases, but I'll use cancer as an example. In advanced countries, and I'm going to use that before we come back here, because we also have means. There are many ways to cope. The first form of coping is counseling. Your medical provider, your doctor has a very, very serious job to do, because apart from treating you, it's part of his job to break news to you in a manner that you can accommodate. He has to tell, if no matter how bad such news is, he has to find a way, walk around words, walk around your emotions and psychology, and present the information in a way that your brain can assimilate and you can handle and be stable. So the first coping mechanism is to have good doctors, good nurses, people that care for you, that will give you their time, attention, and care, and make you feel like somebody who is loved, respected, and cared for. That's the first thing that will help you cope in a terminal disease, because most times the prognosis is very bad, and usually the outcome is death. So you have to be prepared for death. The second thing is, for most of these people in advanced countries, they are granted some wishes. For example, somebody coping with cancer in the terminal phase would have a lot of pain, lots of pain. So in that case, the families are called, and some consents are given by the family, by the individual, if he is in his right state of mind or not in some state where he can make some decisions. And some of these medications that have such effects can be used to help him so that he can cope. Because at the end of the day, the benefit has to outweigh the risk. When you have an individual who is about to die on his sick bed, it's not going to be any nuisance to society. He's not going to go commit crime. He's hospitalized. He has a few months or a few days to die. For such people, the benefit outweighs the risk. So it's a straight yes. They can be given some of these medications. Then the families of these people have to be there for them at most. When somebody that is about to die has his family around, and his family has been able to show some form of care and acceptance, it's different when you have your family crying around you, sad. That makes things worse for you. But when you have a family that has been able to understand the situation, accept it, and are more interested in enjoying the last few days that the individual has with him or her, then it makes coping better for such an individual. Then sometimes at this point of your life, or at this point of the individual's life, he has to be a bit more spiritual. There is room for meditation. There is room for leaning towards your God. There is room for your imam or your pastor or your babalawo, or depending on what he or she serves, to come in and also help stabilize your mental health and prepare you for an afterlife. The reason why is because the thought of an afterlife, or the idea of an afterlife, makes living this current life easier for patients. So these are some of the coping mechanisms that somebody living with a terminal disease, depending on how close it is, can also do. He can also develop a skill. I see some people, when they grow older, they learn new things. Some people learn how to knit. Somebody learns how to play the keyboard for the first time. I have an uncle who is not so elderly. He's not sick, but I just discovered that he started learning how to play the keyboard after retirement, and it's helping him. It's doing a lot for him. It's giving him that zeal to keep moving forward, etc., and opening him up to more things. So I think that would be that for that question. If there are any more contributions on that, I think it could be taken with the permission of the host.
There is a second one.
Yes, sir. Coping with, So how do you cope with the guilt and shame of something like... So initially, when I had this presentation, I was talking about a journal. So we call this thing cognitive-based therapy. Like I said, you need the right professionals. In cognitive-based therapy, you have one-on-one therapy with a professional psychologist. They call them shrinks outside the country. The reason why you need them is, first of all, they have confidentiality at the back of their operation. So they're not going to take your information anywhere. There's nothing to be ashamed of. It's a personal conversation between you and your psychologist. Your information is very safe with them. In fact, it's absolutely illegal for your information to be transferred from there without your consent. So when you sit down in that environment with a shrink, the person will put you in a comfortable position for you to express yourself. I'm not going to go into discussing some of the tactics that they would use to do that. That is professionals at their discretion. But at the end of the day, just missing the opportunity to see a psychologist might make you end up having guilt and shame, because they are the ones that will tell you that, look, there are other people like you, etc. Secondly, when you have focus groups or support groups, you have people that would actually reassure you that you're not the first. These things have happened to so many other people before. Can you hear me, madam? They'll make you know that you're not the first. They will find ways to make you open up. You have other group sessions with people that have the same or similar issues with yourself, and you can share ideas so that you find out that you're not alone. Over time, when you start writing in your journal and reflecting on the kind of person that you want to be, you know, I mean, we all have ambitious dreams, and so long as you're not dead, you can always do something new. Every day you wake up is a day to do something new. So you can write the things you want to do, sit down, read about the person that you want to be, reflect on it, and gradually with time, by leaning closer to focus groups that will help you discover yourself, you know, making better networks and connections within those groups, you find yourself, you know, coming out of that shame and guilt. Shame and guilt is one thing, being a felon or a criminal is another thing. If your use of drugs in the past did not lead you into the line where you became a convicted criminal, then you even still have a better opportunity compared to somebody who is a convicted criminal and might come out and not have an opportunity for a proper job, etc. So your process is rehabilitation, and in the rehabilitation cycle, there are so many steps, including counseling and you know, reading motivational books, talking to the right people like your psychologist, having your therapies, etc. These things over time should be able to clear away any form of shame or guilt. But I'll tell you that from time to time, there's always a possibility of you reflecting, even after a long time, even after you've become established. I mean, it's part of your life. It's very difficult to forget. But so long as you're making progress every day, I think you should focus more on the positive than the negative. Thank you.
All right, thank you there, Dr. Allen, focusing more on the positive and than the negative. That leads me to, fortunately, we have a lot of our stakeholders. I think very soon again, we have to bring this issue of stigmatization as a discussion on this space, because um, I actually did prepare to say this, but then I'll try as much as possible to say it in the best possible way. I think we all have to, all the stakeholders here, we really need to do a lot by sensitizing our society on this problem of stigmatization. Now, I'll say it that indeed we have, I have a very popular celebrity who recently went into rehab and came out, and this person has not been able to come out in the public because of this fear. And we've been engaging with this person now for weeks now, just to encourage her to be able to own her narration, tell her story, to encourage others. And but because of the fear, oh, if I come back, they will drag me, they will do this, they will, oh my God. So I think we need to do a lot to encourage, to educate our people about this thing. I mean, celebrities, whoever they may be, or even any other person, these are human beings. Their mental health matters. So we have to really be very sensitive to this problem of stigmatizing people or judging them, because you don't know their story. Now, by the time I personally listened to this very popular celebrity, if I say popular, very popular celebrity, I felt for her. Well, I wouldn't know whether she told me the whole truth, but then I think she had things going wrong, and so that one thing led to the other. But now she's gone into, the person has gone into rehab, come out, and now to live a normal life is a huge problem because of the fear of stigmatization. Because the person is afraid of what the society, what the millions of followers on social media will do or will say. So I think we all have to take this as a challenge so that we can continue to address this in all our engagements. That said, let's get to something to say. Arewa Poet, if you are not ready, I'll move on to the next one. I know Loretta is coming on board. Let me take the next question. We have quite a lot of questions in our DM here. Okay, Arewa Poet, are you ready?
No, I will speak after one more person, please.
Okay, please, Loretta, welcome. Let's go ahead with Loretta before I go back to our DM.
Good evening, everyone. It's just that you pinched me where you pinched my balloon, and that's about stigma, And
Yeah, absolutely. I'll tell you, Loretta, there is somebody at the moment. The person just left my office not quite long, and this thing has been going on for weeks, trying to encourage the person, trying to mobilize the person to come out and tell the story so that um, the person can get free from this fear of the person. You can touch the fear in the person's face. I mean, fear, stigmatization. Oh, they will finish me. Oh, they will say they will say that, and I see, Kai, why would our society? And indeed, I can feel for this same person, because I know if the person dares come out at any event or social media to say pain that's what everybody will come after the person. And I think we really need to all our stakeholders to address this issue again. That's why I hope to bring this up. Maybe even our next conversation we'll have a group of stakeholders. Let's talk about this stigmatization again. It's really not. These people are really not really. They are feeling it. They are afraid of it, and it's really. And the person is talking about. I mean, will these people allow me to live my life, or this thing is driving me back? I'm trying to avoid giving any clue that would lead to, I mean, who the person is. But then, so that's the kind of scenario we have at the moment. Loretta, please go ahead.
yeah, two things quickly, Mr. Babafemi. One, it's okay, you can refer the person to us. Sometimes there's a lot we do with people.
Yeah, I know what I mean. These are people that can only speak to. They are not even. They don't even know who they are even afraid to talk to anybody.
That's the more reason why they should talk to someone they don't know or does not know them. And so we'll talk about that one later. So about stigma, I've always said that the culture of Nigeria, the culture of Africa, the way it is, our cultural fiber, the way it is structured, the way it is lived, or our belief system will always give room for stigma. Oh, before I continue, Dr. West, absolutely wonderful presentation. Thank you so much. I learned quite a lot from you today. Thank you super much. And are you still in Ukraine?
No, madam, I'm in Nigeria. Thank you very much.
Loretta, I told you Dr. Allen works with NDLA. You and Dr. Kevin, you don't listen. That means you don't listen to me in the early parts of this.
So I came in slightly 25 minutes after 9 a.m.
Yeah. That's your 9. That's your 9. Not our 9.
Okay, you're 3 p.m. So I missed that, but I was very attentive to everything he said. So for stigma, you remember, and I'm putting this out to everyone that is listening to me. We all remember the HIV drama, right? Remember that when HIV came, anyone that had HIV around us, most people would lock them in a room. They will throw food to them through the under the door, or open slightly and throw food at them. It was a death sentence. And we had to do, then I worked with the PEPFAR project. We had to do super sensitization. We had to do super community education. We had to do a lot of work. Today, we have family members who are HIV positive, and we eat with them. We share the same spoon with them. We hug them. They are married. They have kids. So, sir, I know we are not there yet. It will take a while, but we'll get there. If we could overcome the stigma associated with HIV/AIDS, we will overcome this. And that is why I keep saying that the work is at the community level. That is why I keep saying community stakeholders are the ones responsible for perception change. We need perception change in perception. We need to let people know that people use drugs for different reasons. we need to know that even amongst us, even specialists, amongst us, specialists, some people I know even using cannabis to calm themselves down or as stimulants, whatever it is. So I'm saying that this stigma issue, it's a long journey, but we'll get there, and it starts from us.
Absolutely. That. Where is that, Dr. Kemi? Mute yourself. Yeah, that siren is coming from you.
And something very important. He said the family unit is the important unit.
Yeah, he did say that.
Once the family can accept an individual going through the substance use challenge, that is the first hurdle they have broke or they've crossed in terms of stigma. Once your family, the morally deficient, the morally sick person of a society, they don't blame the victim. There's something we call blaming the victim. You don't blame the victim. You accept them the way you are and support them.
That's
yeah, I'm done.
All right, thank you very much, there, Dr. Loretta. I'll come to before. I think if not possible, this the next edition it will have to be the week after. I think we all of us have to come on this space to speak with one voice on this issue of stigmatization, so that we can all condemn it and actually speak, appeal to our people. Actually, this person specifically asked for us to speak against stigmatization because it's killing the person, even despite the efforts to get out of rehab and live the person's normal life and what have you. But then all will be well. I think we should all rally and get to do something about this. All right, let's get Arewa Poet, please go ahead.
Yes, good evening, everyone.
We can all hear you. Please go ahead.
Good evening, sir. I can hear you. Thank you.
Okay. So, like I was saying, on my voice, stigmatization, we need to up, we need to desensitize, we need to up the sensation. Very, 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 very important. Super important. Thank you. So back to business. Great job, doctor. Excellent presentation. You did a fantastic job. Well done. Your enthusiasm and expertise shown thoroughly. Thanks for sharing your expertise. Really, really useful and this is resonated with me so well, so perfectly. I was actually on the picture of the story. Basically, like the character of the way you were speaking on my behalf.
There is really a lot of interruption. I don't know whether it's your phone, your system is very okay. Better now. Yeah, better now. Yeah, Arewa Poet, can you hear me? I think it's the system he's using. Okay, Alan, if you heard him, you want to speak to what he said? Arewa Poet?
Yes, can you hear me?
Okay, you are better.
Okay, yes, we can hear you now. I couldn't hear before.
Yeah, I wasn't also hearing before. Go ahead, please.
Yeah, can you hear me now?
Yes, you are very clear now.
Yeah, so I was saying, you get my initial point that I said. I was just appreciating Doctor for a wonderful presentation on what he did. Excellent job there, and we also need to up our game on the issue of stigmatization. It's actually doing a lot of damage, especially at the community level. However, I would on my intervention, I would rather concentrate on the need to actually have support groups at our community level. We need to engage the community level. in addressing these issues. We need to engage the community level. We need to encourage communication and communication among the users. It's very, very important. It's very, very important. These are measures. These are key measures towards addressing these multifaceted challenges that requires. It's a multifaceted challenge that it requires a comprehensive approach in addressing that. Which is why everyone at the community level must get involved. Everyone, especially our worship centers, the mosques, the churches, the schools, youth organization, the media, both the mainstream and especially the social media right now, especially the social media, it's very, very important. Very, very important. To the users, I just want to say yes, or remind them that seeking help is essential. It's for managing medical conditions and overcoming substance abuse. Thank you very much, Mr. Femi. Thank you very much. Thank you, doctor. Thank you.
All right, thank you very much, Arewa Poet. Dr. Allen, you want to say something?
Thank you very much. No, thank you very much. And like you rightfully said, community stakeholding is very important. It's a collective approach. No particular stakeholder will be able to achieve it alone. And the truth of the matter is that we just need more generally. We need more human resources, more human development, capacity building for some of these people who will be the experts in providing support to some of these vulnerable people. We need more funding, private, government. We just need more, because to be very honest, if you look at a country's development comes from its human resources mostly. So we should be found investing more in ensuring that our human capital resource is devoid of addiction, devoid of drug abuse, etc. And those who are involved in it, it is actually good business to actually rehabilitate these people. It's not a liability, that's a good investment for the country. And all stakeholders should try as much as possible to do more. We're doing well, but we can do more. So that's the message. Thank you.
All right, thank you there, Dr. Allen. Okay, Voyage, any question or intervention? Voyage FX. Okay, if Voyage is not ready, let me come to Official OG. Official OG.
No, I don't have anything to say for now. I support everything, though that I didn't get the time.
Okay, that's okay. Okay, that's okay. Thank you. All right, Official OG.
Yeah, I don't have anything to say.
Okay, you too. Okay. All of you would have. Okay, let me quickly get this from DM. Quite a number of messages here. Let me see if we can still attend to one or two of them before the time is out. Where is this one? There's a particular one I was looking for. Mindfulness, blah, blah, blah. What are the challenges of managing multiple chronic? Okay, this one, Dr. Allen, this one also it's still about medical conditions. But, okay, I've listened to the presentation by Dr. Allen, but I still need him to expatiate more on managing multiple chronic conditions simultaneously, challenges of managing multiple chronic conditions simultaneously. That's another angle to it, managing multiple chronic conditions simultaneously. Okay, please go ahead.
Okay, thank you very much. While we're talking at the beginning of the lecture, we talked about the different kinds of medical challenges, and we talked about a lot of them, genetic medical challenges. We also talked about concomitant medical challenges, which means having two or more medical issues at the same time. We have that especially amongst our elderly. We also have that with people living with some autoimmune disorders. We have that with people who have immune disorders like your HIV, etc. At some stages, you see these people having kidney damage, liver damage, heart heart malfunctioning or dysfunctioning, etc. So what do we do? First thing I'll tell you is that no two cases are ever the same. No two patients are ever the same. So it depends on the case management that is before the doctor. You have to take your time to actually assess the case. You also have to schedule treatment based on a scale of preference and understanding the way the body works. All systems are important to the body, but some systems may not be able to do without, the others. Take for example, you have a diabetic patient who requires a surgery for a total hip replacement. He also has hypertension. The doctor knows that before he can even go into that theater, he has to make sure that that patient's blood pressure is stable, because the anesthesiologist is depending on the doctor to make sure that happens, because he's going to give him some drugs. And anesthesiologists, we have analgesics, some are opioid, etc. The anesthesiologists know how they play around with anesthetics, and they know that if the person has hypertension, it might take his life in the theater. So they have to now look at the benefit and the risk and have a plan. You must always have a plan. So as much as the surgery is important, because the patient will probably be in excruciating pain, cannot walk well, they cannot do that surgery until they bring down the blood pressure. Until they stabilize his blood sugar, they will not attempt to do that surgery, no matter how important it is at the time, because it's possible that if the blood sugar is not stabilized, that patient might never heal from his surgical wounds. That can lead to sepsis, infection, and instead of you trying to resolve a problem, you create a bigger problem. So management of comorbidities is at the discretion of the doctor's ability to carry out a thorough assessment of the situation. Now, when you're dealing, when we now want to talk about managing comorbidities and its nexus with using certain medications, just like Dr. Kemi Oluloyo was saying, we need more. We have emerging trends. There are new things happening in medicine every day. Doctors, nurses, pharmacists are aware, but those that are aware, they need to train other people. They need to expose this information. We have a thing for hoarding information in Africa. I'm not going to say Nigeria. Information should be disseminated across board. The Medical Dental Council of Nigeria, the Association of Pharmacists, Association of Psychiatrists, we have doctors that are in federal government, state government, but what about doctors in the private sector? We should share information with one another. We should not work in isolation. Whatever things are being updated outside the country, we should have an avenue as stakeholders to share this information, not marginalize one another. So there are other drugs that can be used, but I'll always tell you that the benefit will outweigh the risk. If a doctor gives an assessment that the patient really needs it, it's his job to make sure that he counsels that patient and reduces every risk of that patient getting into addiction. Mind you, there are processes for withdrawing patients off certain opioid substances. For example, you have a surgery, maybe a heavy analgesic, for example. You notice that over time, when the pain is gradually reducing, the patient might not know because he's already used to that particular level of serenity and peace and tranquility, no pain at all. But it's your job to also stand firm. You reduce the doses. From reducing the doses, you move to lower painkillers or lower analgesic agents, and then you now gradually tailor them out of that phase and take them to the regular painkillers that don't have any narcotic trace whatsoever. Sometimes the patients will try to exaggerate their pain and try to make you feel guilty, like you're trying to maltreat them. But as a doctor, you need to be able to delineate between a patient that is hysterical and a patient who is actually honest. And there are many tricks you can use. Sometimes I'll tell you, in my profession, I've actually given a patient injection water while I was trying to get her off pentazocine after her cesarean section. And she always call, she would scream. The nurses would be wondering, where's Dr. Allen? She was giving me sleepless nights. In fact, during that era, I could not sleep during my calls. And one day I just came and I got an injection water, which is just normal sodium chloride, and I just put it in injection, and I just injected her in her vein because I know it's not going to cause any harm. And I told her that was pentazocine, and she kept quiet for the next 6 hours. So you need to be able to study your patients, and when you're dealing with something that has to do with mental health, you need the experts. You need the experts to guide you. Thank you.
All right, thank you very much there, Dr. Allen. We are almost on that hour, but quickly, I think I may have to give somebody the last. Yeah, I see you, Olalekan Olaya. Please go ahead. You are most likely the last person to be given this opportunity. I pray
Thank you.
you are clear. Very yeah. Go ahead, please.
Thank you very much, sir. Mine is coming in the form of questions. Like 25 years ago, when I was much younger, when they say someone, when they point at someone and say that man takes cannabis, we have this way we look at them, oh wow, it's coming from him, it's a wrong thing, stuff like that. But nowadays it is rampant, and everywhere, every company can is carrying one a roll of cannabis on their hands. What do the statistics show, sir? Over the time, are we winning this war, or is the men is winning the war? That is one. Then secondly, in other times, we have medical advancements. Some of these drugs are said to help in managing cancer and stuff like that. Are we looking at such in our own environment as well? Those are the two questions I would like to ask. Thank you very much.
All right, there. Thank you. I think on the one hand, if I get Olalekan very well, on the one hand, is asking why we have more abuse of cannabis on the streets everywhere. And on the other hand, he's also talking about the medical use of the same substance in other parts of the world, other part of the world. And so why are we not looking in that direction here? I get Lekon, I believe that those are your questions, right?
Yeah, the first one is looking at the statistics. Are we winning the war? Because years back, people did not carry cannabis all over, but we see it now. So what do the statistics? Are we winning the war? That's my first question. Then the second one is, are we looking at the medical aspect of it as well?
All right, thank you. Okay, let me leave Dr. Allen answer the one you can, especially the medical use of it. Why I can always take care of the first leg of his question. If you can, please go ahead.
Okay, thank you very much, sir. So, what I would say is, first of all, some things you've discussed about are policy issues at higher levels that I might not be competent to speak about. But what I can tell you is, of course, marijuana, cannabis actually came out as a plant, and over time it was abused, and different countries have different control measures that depends on a lot of factors, their infrastructure, their GDP, their political will, etc., that make them come about certain laws. There is something called diversion, and diversion is actually a serious issue internationally or globally. A diversion of substances is a serious issue. So until you have mechanisms in place that can monitor and evaluate proper liaisons, a solid structure, then I think Nigeria we're still away from that at the time. The medical uses of marijuana, like you talk about, maybe talking about glaucoma, or for use in patients with cancer at terminal stages, sometimes for people with people that have diseases as a result of very poor immune systems, like HIV, opportunistic infections, etc. Sometimes at the terminal stages, they have loss of appetite, and studies had showed that cannabis would actually help that. Some people have alopecia, very, very poor hair growth. I'm sure if you look at some of your hair creams on the market, you see some of them contain cannabis. It's written there because cannabis has the property to regrow hair cells. So I'm sure there've been a lot of extensive research on cannabis for health. But if you look at the emerging trends in the production of illicit synthetic cannabis, you will find out that it was a research on cannabis that developed the JW018 by Fubanaka. This particular cannabis has given way to more strains of illicit synthetic cannabis that are now even a bigger problem to us as a nation and globally. the conversations around them have not been very, very high end. We still talk about these ones because they are more newer substances. Every day, the SIDAPA Act is being developed, new drugs. When they get to find out about these particular strains of cannabis, it becomes a law enforcement situation, and the Chinese develop another one. So we have to look at things from managing things. In the course of trying to advance healthcare, we should not create a bigger problem. As a medical doctor, that would be my opinion. Um, I mean, we have hair creams, we don't manufacture them. That should be an issue for policy legislature at that level. But in my own case, I would not. I don't think Nigeria is ripe enough yet to have that kind of policy. Thank you.
All right, thank you very much there, Dr. Allen Aluge. If I may add to what he said, I'll tell Malalikon that indeed we're winning the war and we're going to win the war by the grace of God, because where we were some 5 years ago is not where we are today, absolutely. With the volume of, if I have to if I have to, okay, with the volume of drugs that NDLA through drug control mechanisms and enforcement had taken out of circulation and communities alone, that's huge. That's just imagine if all of that had been in circulation in our communities, and the level of awareness about this problem now, because this is all about creating awareness, is all about sensitizing the people first to ensure that we prevent more people from slipping into substance abuse, and for those that are already struggling with substance abuse, to also provide them help. And all of these steps, all of these we are doing at the moment. The nation that is Nigeria is doing at the moment. We have the whole of government approach to it. We have the whole of society approach to it, meaning that we are not where we were before, and we're making impact, and significant impact for that matter. So that's what matters. Those are all those are all factors. These are all signs of us getting over this problem. It's not one yet anywhere in the world, but then the journey of 1,000 miles starts with the first step. So we're taking the right steps, and so we're very confident and very 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 sure about it that we're going to win. And that's that. And I'm sure Alan had answered the other leg of your question very well. That's regarding cannabis. With 10.6 million, almost 11 million people as of 2018 between ages 15 and 64 abusing cannabis, our nation cannot afford to play with that for now. We especially given the strong nexus between that particular the abuse of that particular substance and the rate of criminalities, or the challenge of criminalities or crime that we have across the country. We cannot toy with that at the moment. And even when you look at those other jurisdictions where these have been allowed, legalized, you can see quite a number of them are coming back again to say, no, we have to. I mean, there was a very beautiful, a very comprehensive report on this in the New York Times some 3 weeks ago on this. But a lot of the jurisdiction, they are rescinding their decision on that particular decision of allowing free use of this. So that's where we stand at the moment. I would like to appreciate everyone. The time is past the hour already. Unfortunately, more people are coming in to ask. Jamil, thank you. Unfortunately, that's Jamila. I would have loved to take your reaction, but then let's do this again together next week. Unfortunately, because we are past the hour, we can't hold everybody, pin everybody down here. Dr. Kemi is past the hour, so I'll appreciate if we hold our thoughts for next week. So I'd like to appreciate everyone, Dr. Kemi Oluloyo, Dr. Loretta, Dr. Azia Damubi, all of those joining us from across the world. Thank you very much for being a part of this conversation today. I'd like to also appreciate my colleagues supporting from behind the scene, all of those in the studio, all of those in Lagos and across every part of this country. Thank you very much. That is Rita, Shidi, Musa, Francis, Dele, Mahmoud, Neta, Comfort, Kumbi, Vina. I appreciate all of you. God bless you all. Let's enjoy our weekend in moderation, and we'll catch you again next week, Friday, same time, by the grace of Almighty God. Mba, and I hand over to Mahmoud. Bye-bye from here.
Thank you very much, sir.
Don't do drugs. Don't do drugs. Don't try. Today. Even though, even though, even though, even though, even though it not to me, even to my body, oh, even though it not by me, it don't buy somebody, oh, even though you never, even though you want to, I beg you no bother, you go